Bismillahirrahmanirrahim. In the last lecture, I started with the rectum and diseases, and my topic was surgical anatomy of the rectum. Today, I am going to talk about the rectal injuries, foreign body rectum, and rectal prolapse. Before going on to the topic of today's lecture, I will like to enumerate the different symptomatology, common symptomatology, symptoms with which the rectal diseases they present with. These symptoms with which the rectal disease they present, one is bleeding per rectum, it's a very common symptom, altered bowel habit, another very significant and important symptom which must be given a significance, discharge with maybe mucus and pus, and which usually associated with rectal inflammation. Tenesmus is another symptom of rectal disease, often described by the patient as I feel I want to go but nothing happens. This is normally an ominous symptom of rectal carcinoma. Another presentation of rectal disease is rectal prolapse. Then pain, which is also called proctalgia. These are the common symptoms with which the majority of the rectal disease they present with. Then the signs of rectal disease which we elicit. This is basically on examination, which is by inspection of the perineal area, and then digital examination of the anus, anal canal, rectum. Then proctoscopy helps us in the examination and to elicit the physical signs which are present, and sigmoidoscopy, which is rigid as well as flexible sigmoidoscopes. These are available and they are used for examination of the anal canal and rectum. Now coming on to the topic of today's lecture, if we talk about the rectal injuries, the rectum and anal canal may be injured in a number of ways. It's all uncommon. Number one, by falling in a sitting posture. You can imagine when a person can fall in a sitting posture onto a pointed object, like the upturned leg of a chair, handle of a broom, floor mop, pitched fork, or a broken shooting stick, have all resulted in rectal impalement. So this is one way of rectal injury. Another way in which the rectal injuries occur is by trauma, and this is basically it is blunt trauma. Sometimes the fractured pelvis, they are associated with the rectal injuries, and then penetrating injuries. And penetrating injuries can be by deep stab injuries, but usually nowadays it is the gunshot injuries to the buttock which result in the injuries of rectum. Third, rectal injuries can occur by sexual assault or sexual activity involving anal penetration. This is again another way in rectal injury can occur. Obstetrical injuries of the rectum. This occurs during childbirth by the fetal head, especially when the forceps assisted deliveries they are done. So in those cases, rectal injuries can occur. Now, regarding diagnosis, we have to do clinical assessment, investigation. And what is clinical assessment in this case? For diagnosis, the anus should be anal opening, perineal area must be examined, inspected, and then abdomen should be palpated. If there is a intraperitoneal injury, if there is injury of the intraperitoneal part of the rectum, then on abdominal examination there will be rigidity and tenderness, and in those cases this requires early laparotomy and laparoscopy for management and diagnosis as well as management. Regarding investigation, a water-soluble contrast enema or computed tomography, that is CT scan, will be helpful with contrast, will be helpful to identify rectal injury or perforation. Ureterogram sometimes is done in these cases when there is any possibility of urethral injury, which is suggested by difficulty in passing urine, hematuria, blood at the tip of the meatus, external meatus, or high prostate on digital examination. So that usually occurs in blunt injuries when there is a fractured pelvis. This can occur in those cases. So treatment of rectal injuries, what is important? Examination, usually in these patients, there is a examination and anesthesia is done, digital rectal examination, then proctoscopy, sigmoidoscopy is done to confirm the rectal injury or perforation. If there is intraperitoneal injury of the rectum, obviously it must be followed by we have to do exploratory laparotomy. Sometimes laparoscopic exploration can also be done in these cases nowadays. For intraperitoneal injury, we usually can do primary closure, but primary closure must be accompanied with defunctioning sigmoid colostomy in the left iliac fossa. Then the lower one-third of the rectum is extraperitoneal. So extraperitoneal injuries of the rectum can also occur. In these cases, debridement, drainage from below, and then a diverting, defunctioning sigmoid colostomy in left iliac fossa is usually done. But while doing debridement in this area, we have to specially care for to preserve the sphincter during this debridement. Sometimes in intraperitoneal injury, when it is extensive, when it's a large rectal injury and we have done the laparotomy and we cannot repair the injury, so what we have to do in those patients, we can do Hartmann procedure. This is another option for intraperitoneal large rectal injuries. In the end, what is important, all these procedures, they must be accompanied with a good antibiotic cover, especially gram-negative anaerobes, gram-negative coliform bacteria, they must be covered. So antibiotic cover is very important, and this is always with all the surgical procedure which are done for these injuries. Now, if we talk about the foreign bodies in the rectum, colorectal foreign bodies are not an uncommon presentation in the emergency or a colorectal surgical department. Rectal foreign bodies often pose a challenging diagnostic and a management dilemma that begins with the initial evaluation in the emergency department, and then it continues through the post-extraction period. So objects can be inserted, these foreign body can be inserted into the rectum for example, diagnostic or therapeutic purposes. Sometimes this may be the cause of foreign body in the rectum. Then self-treatment of inorectal diseases by the patient, that can result in foreign body in the rectum. Then foreign body in the rectum may be due to criminal assault or accidents. But the most common cause of foreign body rectum is due to sexual purposes. Patients with rectal foreign bodies are embarrassed, and often they are reluctant to state the true nature of their emergency room visit. Here, there are a few pictures. You can see this is a pepper pot in the rectum. Here you can see this one. This is a foreign body in the rectum. Another photograph, screwdriver with a plastic handle as a foreign body of the rectum. These are two another types of foreign body. You can see live shell, then a large vibrator is there in the rectum, which is used for sexual purposes, for sexual pleasure. This is again sometimes slips and presents as a foreign body in the rectum. Clinical presentation in these patients, chief complaint, patient they present with rectal pain or abdominal pain. There may be bright red blood per rectum. There may be inability to have a bowel movement, and there may be rectal mucus leakage when there is a foreign body inside the rectum. In most of the cases, patient present several hours to days after the placement of the rectal foreign body. And on occasion, the foreign body has been even successfully removed, but the patient presents because the patient has delayed symptoms of bleeding, perforation, or even incontinence, then they present late. So physical examination in these patients. Now, if the object is distal and no significant trauma is present, then the examination can be quite benign in these patients. Frank peritonitis can occur if there is perforation above the peritoneal, that means in the intraperitoneal part of the rectum. In those cases, obviously, if there is injury, perforation due to foreign body, then will be a peritonitis. These are often palpable through the rectum. These palpable rectal foreign body, it can be palpated in either in the left or right lower quadrant. Sometimes this can occur, that you can palpate this foreign body in the left or right lower quadrant of the abdomen on abdominal palpation. The rectal examination, which is palpable in the on rectal examination, the foreign body may be palpable in the distal rectum. And if higher up may not be able to feel it, we are not able to feel it on digital examination. Bright red color per rectum is often seen, but it is not always present. That means, and it's not always that blood will be there in foreign body, and should not be interpreted as minimal injury. That means if blood is not there, that doesn't mean then the injury due to foreign body is minimal. Careful attention for status of the sphincter. That means we have to see what is the status of the sphincter on digital examination in these patients. Treatment. In majority of the patient, these foreign bodies can be retrieved through the per annum. Sometimes different methods we have to use to extract these foreign bodies from the through the anal orifice. The difficulty lies in the creation of a vacuum effect when trying to extract the object through the anus. But if insurmountable difficulty is expected in grasping any foreign body in the rectum, laparotomy is usually necessary. Sometimes we have to do the laparotomy, but in those cases, again, we can push the foreign body and the object can be pushed down into the assistant finger in the rectum, or removed by means of a rectotomy in a proximal area of the rectum. If there is considerable laceration of the mucosa, a temporary colostomy sometimes is visible. So these are the procedures which are done. Usually foreign body can be retrieved through the anus. Sometimes it is assisted with the laparotomy and foreign body is pushed from above downwards and retrieved through the anal opening. And very uncommonly, rarely these foreign bodies, we have to open the rectum and rectotomy, that opening in the rectum we have, and retrieving the foreign body through that opening. These injuries, there is a serious risk of associated necrotizing fasciitis. That means anaerobic infection, especially the clostridial infection, which occurs if there is a perforation, especially in the extraperitoneal injury of the rectum associated with the foreign body. And in those cases, we have to put on patient on broad spectrum antibiotics and covering the anaerobes, especially, and gram positive as well as gram negative anaerobes. Then we come to the rectal prolapse. What is rectal prolapse? It is circumferential descent of the rectum bowel through the anal canal. Rectal prolapse can be partial or rectal prolapse can be complete. So these are two varieties, and sometimes we also call the partial prolapse, the incomplete prolapse, this is mucosal prolapse. And when there is a whole complete prolapse, all the walls of the rectum, they are in the prolapse part. So full thickness, complete prolapse is also called full thickness prolapse. Mucosal are also called partial prolapse. The mucous membrane and the submucosa of the rectum protrudes outside the anus for approximately, you can say, 1 to 4 centimeters. So in cases of mucosal prolapse, mucus, mucosa and submucosa of the rectum, that protrudes outside the anus opening, and usually the length is about 1 to 4 centimeters. And in these cases, when we palpate this prolapse mucosa between index and thumb and index finger, it is evident that it is composed of no more than a double layer of mucous membrane. So as compared to complete prolapse, it is thin one. We can feel the 2 layers of the mucosa in between thumb and index finger. Why this mucosal prolapse occurs? What is the etiology? Now, in infants, the reason is that the direct downward course of the rectum, it predisposes to this condition, because sacral hollow is not developed in these infants. Reduced resting anal tone, which offers diminished support to the mucosal lining of the anal canal, is the other cause in infants for the mucosal prolapse. In children, the cause may be after an attack of diarrhea, straining, or from loss of weight, and this loss of weight leading to loss of fat in the ischiorectal fossa, which provides a support to the rectum. It may also be associated with, in case of children, with cystic fibrosis, neurological causes, and the maldevelopment of the pelvis, which can result in the mucosal prolapse in children. Now, in adults, what is the reason of this mucosal prolapse? This is often associated with third-degree hemorrhoids. And sometimes this is also called mucohemorrhoidal prolapse of the anorectum. In the female, a torn perineum may be due to obstetrical causes, and in the male, straining from urethral obstruction. That can result in adults with mucosal prolapse. In old age, both mucosal and full thickness prolapse are associated with weakness of the sphincter. Then that means in old elderly people, mucosal as well as complete or full thickness prolapse may be associated with weakness of the sphincter mechanism. So in those cases we assess, in all the cases we assess the anal sphincter. But usually these are the elderly where weakness of the sphincter mechanism is usually found. It may follow an operation for fistula in ano. After fistulectomy, a partial prolapse or one side of the area where the operation, part of the anal verge where the operation has been done in fistula in ano, that can result in the partial one side part of that can prolapse through the anal opening. Now, prolapsed, and how we can differentiate between hemorrhoid and the prolapse. Prolapsed mucous membrane is pink in color. So if it is a prolapse of the rectum and there is mucosa, the color will be pink. While prolapsed internal hemorrhoids, they are plum colored and they are more pedunculated. So this is how we can differentiate it. This is one differential diagnosis: prolapsed hemorrhoids and prolapse of the rectum. So this is one point we can differentiate between prolapse rectum and the prolapse hemorrhoids. So treatment. In infants and young children, it is the one way is that by digital repositioning of the prolapse. The parents, they are taught to replace the protrusion and address any underlying cause. Then submucosal injection or bending. If the digital repositioning fails after a 6-week trial, injection of 5% phenol almond oil. Nowadays we use STD as a sclerosing agent and inject and this is usually done under general anesthesia in these children. Surgery in these patients with mucosal prolapse in infants and young children is very uncommonly done. Occasionally that is done and the child is placed in the prone jackknife position and we approach in the retrorectal space, enter the retro just below the coccyx, and the rectum is sutured to the hollow of the sacrum. This is through the perineal approach. Very, very uncommonly this procedure is done in mucosal prolapse in cases of infants and young children. Now the treatment of mucosal prolapse in adults. Local treatment, again we can inject sclerosing agents in the prolapsed mucosa, resulting in fibrosis and retracting inside the anal. So also we can apply rubber bands. Again this causes fibrosis and that can result in retraction of the mucosa and this results in relieving of prolapse, mucosal prolapse. Sometimes excision of the prolapsed mucosa. This is another way to treat the mucosal prolapse. When the prolapse is unilateral, as it occurs in, like I told you, in after operation in the fistula in ano. So when there is a unilateral prolapse, mucosa on one side is prolapsed, the redundant mucosa can be excised. Even in circumferential mucosal prolapse, an endoluminal stapling gun can be used to resect and anastomose the mucosa circumferentially. So this is endoluminal stapling technique which can be done for excision of the circumferential mucosa and treatment of mucosal prolapse in adults. We come to the complete prolapse or the full thickness prolapse, which is also known as procedentia. So the other name for complete or full thickness prolapse is procedentia. It is less common than the mucosal variety. Now, In cases of full thickness prolapse, the protrusion consists of all layers of the rectal wall and is usually associated with weak pelvic floor. This you must keep in mind. Complete prolapse means in the prolapse part, all the layers of the rectal wall are there, while it was not in mucosal prolapse. Only the mucosa where that was prolapse, and it is also the reason may be that the associated there is weakness of the pelvic floor. How this complete prolapse, what is the pathogenesis? The prolapse is thought to commence as an intersusception of the rectum, which descends to protrude outside the. So one concept is this: it is the intersusception of the rectum. Rectum goes downwards and descends into protrude outside the anus. So intersusception of the rectum. What is complete prolapse? Intersusception of the rectum. The process starts with interior wall of the rectum, because interior wall of the rectum is not the supporting tissue are weak. If we imagine the anatomy of the rectum, the interior wall is not, the support is less as compared to the posterior wall, especially in the female. It is more than 4 centimeter and commonly as much as 10 to 15 centimeter in length it can occur. So when we say complete prolapse, it is more than 5 centimeter in length. So it can't be a mucosal prolapse which is more than 5 centimeter. It is mucosal prolapse is usually between 1 to 4 centimeter. But if it is the length of the prolapse is more than 4 centimeter or 5 centimeter, you must keep in mind this is a complete prolapse. The prolapse will contain all the layers of the rectum. As far as 10 to 15 centimeter size of prolapse can also occur complete prolapse. When we palpate a complete prolapse, full thickness prolapse between the index and the thumb, the prolapse feels much thicker than a mucosal prolapse and obviously consists of a double thickness of the entire wall of the rectum. So that's where there's another on examination how we can differentiate between mucosal prolapse and a complete full thickness prolapse. The feeling here, all the coats are there in the walls, that's why it's a double thickness of the entire wall of the rectum. Any prolapse over 5 centimeter length contains interior between its layers a pouch of peritoneum. So here you can see when the prolapse is more than 5 centimeter, anteriorly a pouch of peritoneum also descends along the interior wall of the, so that forms a hernial sac. So here you can see this is a peritoneum which is dragged along the interior wall of the prolapsed rectum. In this figure, this is here you can see this is peritoneal sac. So any prolapse which is over 5 centimeter length contains anteriorly between its layer a pouch of peritoneum. So there is a concept hernia. Hernia can occur. When large, it may contain small intestine. So in this hernial sac, pouch of peritoneum, small intestine can enter, and which returns to the general peritoneal cavity with the characteristic gurgle when the prolapse is reduced. So when we reduce the prolapse, a gurgling sound can occur if there is gut in the interior pouch of peritoneum in large prolapse, large complete prolapse. Anal sphincter is characteristically patulous in these patients. Usually, with complete prolapse in majority of the patient, remember anal sphincter is characteristically patulous and it gives widely on straining to allow the rectum to prolapse. Incidence, we talk about the incidence. Complete prolapse is uncommon in children. Keep in mind that point. In adults, it can occur at any age, but it is more common in elderly people. Elderly people, they are more prone to develop this complete full thickness prolapse. Women are affected 6 times more often than the men, and it is commonly associated with prolapse of the uterus. In approximately 50% of the adults, approximately 50% of the adults with prolapse, fecal incontinence is also a feature. So, in complete prolapse in the adults, keep in mind maybe there is associated fecal incontinence. So differential, when we talk about the differential diagnosis in cases of complete full thickness prolapse, a very large ileocecal intussusception in cases of child, rectosigmoid intussusception in adults, sometimes advanced 4th degree prolapse hemorrhoids may come in the differential diagnosis. So these points must be kept in mind when we are talking about the differential diagnosis in cases of complete prolapse. Now, what is the treatment of complete prolapse? Full thickness prolapse. Keep in mind, complete prolapse, surgery is required for these cases, and the operation can be performed via a perineal or abdominal approach. So there are 2 approaches. We can operate on these patients through the perineal approach, or there are operations which are done through the abdominal approach. Abdominal operations can be by an open or laparoscopic approach. So if we operate abdominal approach, both methods are done nowadays. Laparoscopic surgeries are being done for rectal prolapse, as well as the open laparotomy. With laparotomy, we can do abdominal rectopexy. Abdominal rectopexy, either laparoscopic or open, has a low rate of recurrence, less than 10%. So abdominal approach is, in the sense, is better, that it has less chances of recurrence. The rate is less than 10% with abdominal approach. But when the patient is elderly and very frail, a perineal operation is usually safer, and if necessary can be performed under regional anesthesia, anesthetic blockades. As an abdominal procedure risks damage to the pelvic autonomic nerves. This is regarding the abdominal approach. One disadvantage, complication which can occur with abdominal approach is damage to the pelvic autonomic nerves, resulting in possible sexual dysfunction. So in keeping in mind, then even young patient, a perineal approach may be preferred in young men, because this is one complication which can occur with abdominal approach. But if we keep in mind the recurrence, it is abdominal approach which is better as compared to the perineal, because the recurrence rate is less than 10%. The perineal approach, these procedures have been used most frequently. In elderly or very frail patient, a perineal operation performed in a spine anesthetic is usually safer. Procedure performed are as THIERSCH operation, DELORME'S operation, ALTEMEIER'S procedures. These are done through perineal approach. What is THIERSCH operation? This procedure, which aim to place a steel wire or more commonly a silastic or a nylon suture around the anal canal, but nowadays they are obsolete. Disadvantage, there are a number of disadvantages. Suture, they often break. It also causes chronic perineal sepsis. The anal stenosis so created would produce severe functional problems. So this procedure has become obsolete. THIERSCH operation. It is not done nowadays. DELORME'S operation, you can see here. What is DELORME'S operation? In this procedure, the rectal mucosa is stripped circumferentially from the rectum over the length of the prolapse. The underlying muscle is plicated with series of sutures so that the rectal muscle is concentrated towards the anal canal. So you can see mucosectomy, all the layer has been cut, and here interrupted sutures, they are applied to plicate the muscle. So mucosectomy is circumferentially done in this procedure, and then interrupted sutures, they are applied like this to reinforce the muscle layer of the rectum. The excess rectal mucosa is excised and a mucosal anastomosis is performed. So in this case, after suturing the muscle, applying these interrupted sutures, strengthening the muscle, then mucosa is also anastomosed circumferentially. This is DELORME'S operation through perineal approach. What is ALTEMEIER'S procedure? In this procedure, we excise the prolapsed rectum and the if it advanced, and the associated sigmoid colon through the perineal approach, and then construction of a colo-anal anastomosis. So what is ALTEMEIER'S procedure? Whole prolapsed rectum, and if it advanced, sigmoid colon is excised and a colo-anal anastomosis is done. But remember, this is done through the perineal approach from below. This is the advantage of this procedure, but it's not very commonly done. Then abdominal approach. What are the different procedures which we do with abdominal approach? An abdominal rectopexy has a low rate of recurrence. As an abdominal procedure risks damage to the pelvic autonomic, as I previously told you, the abdominal approach, one disadvantage, one complication is nerve injury to the autonomic nerves, which results in a possible sexual dysfunction, and this must be kept in mind when we are doing these operations in young adults. So in those cases, we prefer that if it is possible, we perform through the perineal approach. Abdominal procedure, as I told you, they can be performed laparoscopically or with open technique. Number of procedures they are done from the abdominal approach. These are abdominal rectopexy with mesh, suture rectopexy, resection rectopexy, and anterior rectopexy. These are number of procedures which are done through the abdominal approach. Again, I repeat, this can be done laparoscopically or it can be done with the open technique. The principle of all abdominal operations for rectal prolapse is to fix the rectum in its normal anatomical position. Many variations has been described, as I told you the name of different procedure. For example, including inserting a sheet of polypropylene mesh between the rectum and the sacrum, hitching up the rectosigmoid junction with the Teflon sling, Then and it is done into the front of the sacrum, or sometimes even simply suturing the mobilized rectum to the sacrum using 4 to 6 interrupted non-absorbable sutures. This is called sutured rectopexy. Currently, the technique is most often performed laparoscopically, as I told you. Nowadays, we prefer that if it can be done laparoscopically, that should be preferred. So these are the number of procedures I told you which are done through the abdominal approach. And this is all about this one you can see abdominal rectopexy. Rectosigmoid junction is with the mesh hitched to the sling. It is a sling which has been fixed with the sacral promontory at the level S. This you can see that. This is mesh which has been used to sling the rectosigmoid junction to the sacral promontory. So number of procedures, they are done through the abdominal approach. Keep in mind, the only problem, these are usually preferred in elderly people. In young, we try to perform the procedure from below, perineal approach. Reason is that when we dissect the rectum in this space, in the pre-sacral area, pelvic autonomic nerves there can be injured, and this can result in sexual dysfunction. This is one complication which you must keep in mind when we are doing operation through the abdominal approach. And this is all about the rectal prolapse and its varieties, and what is the treatment, how we treat this person. So in summary, rectal prolapse may be mucosal or full thickness. If full thickness, the whole wall of the rectum is included. It commences as a rectal intussusception. In children, the prolapse is usually mucosal and should be treated conservatively. In the adult, the prolapse is often full thickness and is frequently associated with incontinence. Surgery is necessary for full thickness rectal prolapse. The operation is performed either via the perineal approach or via the abdominal approach. This was a summary to sum up this topic of rectal prolapse. Now, if you have any question, you can ask me through the your WhatsApp group, and answer you. Thank you.